Our first speaker is Dr. Mary Abernathy. We're very excited to have her here today. She's an associate professor of clinical obstetrics and gynecology at the Indiana University School of Medicine. She's been practicing maternal fetal medicine since 1996, so she brings with us a lot of experience. Our state health commissioner, Dr. Box, who some of you may have seen speak this morning, highly recommended her to come and talk about maternal Tdap and influenza recommendations, so we're very excited to have her here. Please welcome Dr. Abernathy.
Okay, so true confessions. So this morning when I was sitting there, I was thinking, thank God, I'm only doing a breakout session. It will be in one of those smaller rooms. So here we go. All right, so I am a maternal fetal medicine physician, and I want to thank you all for being here, and hopefully the postprandial nap will sink in and you won't hear too many of my glitches, but thank you again for being here. Today I'm going to talk about influenza and Tdap vaccination during pregnancy. I have no disclosures. What I hope you get out of this talk, I want to talk and hopefully empower and educate all the providers, and by providers I just don't mean physicians. I'm talking about nurses, MAs, who's ever in your offices that are helping you see the patients and take care of the patients. All those people in those offices I would consider providers. So I want to try to empower you about what causes the flu, what causes pertussis, why do we vaccinate postpartum or during pregnancy and not recommend postpartum vaccination unless they have not had vaccination during the pregnancy, which vaccines are indicated during pregnancy, which are safe, when is the best time to vaccinate during pregnancy for both the influenza, flu, as well as pertussis or whooping cough, how do the vaccines work, and how do they protect pregnant mothers and their newborns? How long do the vaccines last? Because these are the most common questions that your patients, your clients, may ask you. And then I'm going to show you some data about how good we're doing. And this is CDC internet survey data from around the country. So we'll go over a little bit of that in the end. So what causes the flu? Influenza or flu is caused by an RNA virus, which means it has to come in and take over the machinery in all of your cells and then thereby replicate, and that's how you get the flu. There are two types, A and B serotypes. Type A is what causes the pandemics, and those are where 50% of the population contracts the illness. Type A is when we hear of H1N1, H3N2, they're referring to the hemagglutinin and neuraminidase subtypes of type A. 20% of the population normally contracts the flu in any given flu season, but again, in a pandemic, that's where we see up to 50%, and that's caused by type A. We also know that in 2018, it's about the 100th year anniversary of the Spanish flu that happened in 1918, where they're estimating there were more deaths in the world than the deaths in World War I and World War II combined. And again, we had another one in 1957, and we most recently had one in 2009. And the reason those are so severe is because not only do you have that upper respiratory tract infection, but then it migrates down to the lower respiratory tract and you have a secondary bacterial pneumonia that sets in. And that's how it becomes so deadly. So we know that 20% of our pregnant patients will develop a URI or URI symptoms. And if you test everyone, about 10% of those will develop the flu. The recommendation is that any pregnant patient who comes in with a temperature greater than 100 with sore throat and no other explanatory cause should actually be treated with Tamiflu or some similar medication. The symptoms, again, are just like any symptoms of a URI: cough, fever, runny nose, sore throat, headache, myalgias, fibralgias. And so those are the things you want to be watching out for in your pregnant patients. So what causes whooping cough or pertussis? It's actually caused by a bacteria, Bordetella pertussis. And it's characterized, whooping cough came from the name, the characterization of the cough. So if you look at the 3 stages, you have the catarrh, which is the usual runny nose, sneezing, low-grade fever, and that's followed by these paroxysmal coughing spells that you've sometimes heard in very rapid succession, and then at the end they take a whoop. And so that's how it got its name. The 3rd stage is that convalescent stage where the cough becomes less frequent, but it still can hang around by 2 to 3 weeks. And there have been a few people, nurses, that are like, man, I just can't shake this cold. I've had it for like 2 or 3 weeks, and I'm just going, bet it's whooping cough. So anyhow, it's something to think about. The problem with whooping cough disease is that it's a toxin-mediated disease. So even if your patients, even if an infant gets it, and they get the antibiotics, because usually we think bacteria can be cured by antibiotics, right? But once the bacteria are killed, they still can release that toxin. So the best way to prevent illness and death from whooping cough is to make sure that they don't get it in the first place. The other thing to note here is that the volume of cases of whooping cough, and why we're even talking about it today, increased in this country. Since the 1980s, there was a significant increase in this country. Unfortunately, even though you've been vaccinated as a child against whooping cough, that vaccination, that immunity will wax and wane. And so that's why we recommend that every patient woman, every pregnant patient, get vaccinated during each pregnancy with the Tdap vaccine. So why do we vaccinate during pregnancy? Immunization during pregnancy is the best strategy, and how I talk to patients is it's a 2-for-1 deal. Where else do you get that? Maybe Target, I don't know, or Walmart. But anyhow, it's a 2-for-1 strategy, because not only are you, the patient, getting immunized, and it's going to be protective for you, you're also protecting your baby. And I find that that second reason is the one that can usually seal the deal. My office, we do high-risk pregnancy consultations, and probably about every day that I'm seeing patients there, we will give 2 to 3 flu vaccines during that time. And again, that's because we ask every patient, have you had your flu vaccine? And so we're going to go over some of that before. But those people who are somewhat resistant, if I start talking to them about the passive immunization they're giving their babies, they're like, okay, sign me up. So I want to encourage you to think of that. Always think of that 2-for-1. It's active immunity for the mother. It's passive immunity for her infant, because infants can't be immunized early against both either the flu or pertussis early enough. And so we want to make sure that they have that passive immunization, antibodies crossing the placenta and antibodies from the breast milk. It's another reason how to encourage women to breastfeed is that baby gets antibodies that you're producing, and so it's protective. So it's something else I will sometimes use. All pregnant women should receive the inactivated flu vaccine, and this isn't the nasal spray, which we're doing away with for the most part, but all pregnant women should receive the inactivated flu vaccine injection during pregnancy. And when we do that, we find that there's been a 30 to even 70% decrease in the risk of women getting flu during pregnancy. So flu vaccination during pregnancy has been studied, and it's actually shown that it decreases the risk of preterm birth, low birth weight, and infant or fetal death. So it's very important that as providers, we all are on the same page, and we're encouraging our patients to become vaccinated during pregnancy. Cocooning, which was a term that was used earlier by the CDC, and that was to kind of wrap the baby in a cocoon so that everyone became immunized. And so we were immunizing women postpartum. The recommendation before 2012 was that we would be cocooning the baby. Since 2012, we found that if you actually immunize mother during pregnancy for both Tdap as well as the flu, you actually are giving the baby more of those passive antibodies, that passive immunity, and so you're actually doing a much better job of protecting the infant. And so the term cocooning for mothers is one CDC no longer recommends, as we're talking about more active immunization during pregnancy. Cases we found increased from the 1980s, cases of whooping cough. So we had 48,000 in 2012, and shortly thereafter was when they changed their recommendations from cocooning to active immunization of mothers during pregnancy, and they showed that there's been a significant decrease. And that's what we're hoping to do, is to continue to decrease the morbidity and the mortality that we see with both influenza as well as whooping cough. So which vaccines are safe? And if you want to, I think you should have gotten these slides on your app. Print this out, put this in your office, put this on your labor and delivery, because people are always asking. Both the flu and the Tdap vaccinations are recommended by the CDC during pregnancy, and they're safe. Hepatitis B is recommended during pregnancy for women who are at increased risk, and that is defined as greater than one sexual partner in the last 6 months. If you have an elevated, or you're evaluated for an STD, if you have had a history of recent or even current drug abuse, or if you have a hepatitis B positive partner. And so for those women, we're even recommending that they get immunized for hepatitis B during pregnancy. It's also important, if you are from a labor and delivery unit, to ask your patients and assess, because if they have not had it during pregnancy, you still want to not miss that opportunity and to offer both the Tdap as well as the flu vaccine before the patient leaves your labor and delivery unit. At the same time, think of it when you're offering them the MMR. If they are rubella negative, you want to do it at the same time. So safety concerns, these vaccines are safe during pregnancy, influenza, because it's an inactivated vaccination. The pertussis, it's a acellular pertussis fragment, and so you're not actually giving the toxin that can cause damage. Hepatitis B is a viral, recombinant viral subunit. Other ones that may be indicated, depending on the situation, would be hepatitis A, pneumococcal, typhoid, rabies, and meningococcal. Those that are contraindicated during pregnancy are the MMR, as well as varicella, because those are live attenuated vaccines. There's a theoretical risk, although for the most part we haven't seen cases of fetal congenital problems in women who have been inadvertently vaccinated during pregnancy. But you don't want to do it. But again, it would be something that you would want to send someone for evaluation so we could discuss the risk of it. So it's unlikely that they would need to terminate the pregnancy based on having received those. Those that are considered safe for breastfeeding, the flu, obviously, the flu vaccination, Tdap, varicella, meningococcal, hepatitis B, and the inactivated polio. So again, these are considered safe for breastfeeding, and the ones on the top paragraph are considered safe during pregnancy. Any one that is live attenuated, we would not recommend, or those would be contraindicated during pregnancy. So when is the best time to vaccinate for the flu? The CDC initially, several years ago, had come out and said if you're going to be pregnant during the second and third trimester. And a few years ago, they actually changed that and recommended that all pregnant women, regardless of their gestational age, should receive a flu shot during pregnancy, and it's important. It's it's significantly been shown to reduce flu illness in our pregnant patients who have an increased risk, because in pregnancy your immunity is changed somewhat, and so you have a significantly decreased risk of getting the flu illness from the active immunization, as well as obviously those antibodies crossing the placenta and causing fetal issues or neonatal illness, preventing neonatal illness. They've shown that in Norway you can have a 70% reduction in flu illness by immunizing all the mothers. And actually, it's been shown to be protective, decreasing respiratory illness as well as confirmed flu in newborns as well. So when is the best time to immunize for Tdap or whooping, using the Tdap vaccination to prevent whooping cough? The CDC actually, again, changed their recommendation in 2012 such that all women should receive the Tdap vaccine during the late second and third trimester. Preferentially, you do it 27, 28 weeks, which is about the time they get their glucola, RhoGAM if they're Rh negative. So I tend to tag it on to those kind of things that women are usually in tune to. And you can give it obviously less than 2 weeks, but the recommendation, if you're going to try to increase the passive immunity that a mother gives to her infant, the longer the woman has it, the more passive immunity. So if she received it earlier in the pregnancy, meaning earlier than 27 weeks, you would not repeat it. And that's why they're not recommending that this is a preconceptual vaccination. She only needs to receive 1 dose during pregnancy. But again, all the adolescent and the adult family members that are going to be kind of caregivers and taking care of that infant in the home, they should also receive a booster Tdap as well, again, because that immunity will wax and wane. So how do they work to protect the pregnant mothers and the newborns? Again, mothers get that active immunization to decrease the risk of illness, and in pregnancy, that illness can be more severe. And so you want to kind of help actively eliminate that. We know that pertussis infection is much worse in infants, and so it's something to be very mindful of. We know that both those vaccinations produce maternal antibodies that can cross the placenta and can give that newborn passive immunity. We know that newborns cannot be immunized against the flu for until the age of 6 months, and we know that they can't get a pertussis vaccine until 2 months. So you want to give that time between when the newborn is born and when they can be immunized. You want to have that passive immunity from the mother. Antibodies are in breast milk as well, so a breastfed baby, again, will continue to get maternal antibodies. And again, that's another reason, if you have someone on the fence who's not certain about breastfeeding, I push the antibodies. I had a little 35-weeker myself, and I swear to God, I think she got every infection known to man. So I really push that you can give antibodies through that breast milk. And that's key and important for some women to know, and I'll show you some data later to suggest they don't worry about themselves as much when they're a mother, but if you say this can be protective for your newborn, it's a done deal. They'll do it. So how long do the vaccine effects last? Influenza strains, as we all know, shift each season. Most of us in this room probably have to get a flu vaccination. If you work for a health system, you have to get a flu vaccination in order to continue working there. And so you need to get vaccinated every fall and winter. Immunity from the inactivated vaccinations, like Tdap for the pertussis, they wane over time. So a pregnant woman should receive Tdap 27 to 28 or up to 36, 38 weeks in each and every pregnancy. So even if she's had a tetanus vaccination 5 years ago, she should still receive the Tdap to get that increased immunity for her fetus and newborn. So every adolescent and family member in contact with that newborn should also receive a Tdap booster. So what are the best ways to be sure your patients are protected? And this is where I get creative and I say, think Henry Ford. Henry Ford was known because he automated building automobiles. They didn't become, I'm going to have a group of people building this one Ford Model T. He created the assembly line concept, that concept that, you have people doing it. And so if you can think Henry Ford, you want to automate it. And my advice to you would be to take it, don't leave it up to the physicians to talk about it. There's so much other stuff I usually have on my mind that I'm going to talk to this patient about. I fully utilize the nurses, the MAs, whoever is putting that patient into a room. They bring it up. They bring it up during that kind of intake where they're getting their weight, their blood pressure, doing the domestic violence screening, and whatever questions that our health system has them ask. This became one of the questions. Have you received your flu vaccination yet? And so when we room patients in my office, we have a piece of paper. Yes, it all goes into an EMR, but I suggest that most people, most nurses, or who's ever rooming the patient, writes it down on a little piece of paper. Probably irritates the people that run the EMRs to hear that, but I'm going to tell you that's how it is. So, and they'll write down, they'll circle yes, no, or doesn't know, or has already received it. That's the third choice, has already received it. And so the yeses, they automatically take care of. And then the no's are the ones that I kind of focus on. And so that's when I go in and I talk about the active immunity and why it's so important for a woman to have. That's because she can get much sicker while she's pregnant. And then I also talk about the passive immunity. And so it's important for everyone in the office to bring this up, to ask this. And again, that's why I think if you're working in system-mindedness, to automate it and make sure that it's not up to the physician to remember the other 50 things they got to remember during that visit, to remember to ask about that. And so if you automate it so that someone's always asking the question, it will help. The other thing to remember is to assess each and every pregnant about their vaccination status, not only with flu, but also with Tdap during each and every visit. And what I mean by that is you could have kind of a system where you say, okay, you're at 18 weeks, don't forget, we're going to get your glucola when you're near 26 to 28 weeks, and also you'll get your Tdap vaccination then. And so that's where you bring up that conversation and you start them thinking, so that if you're ever in a hurry and busy and forget about it, which we all are going to do at some point, a lot of times the patient will bring it up. Wasn't there some shot I was supposed to get? And so it's just build it into the system, have it automated so that whoever rooms that patient documents each and every time the patient is seen whether or not they've received the flu shot, and that's usually October through May. Our office does give flu vaccinations, and I hope that's why each and all of you are here, because you are required to be here, but to give flu vaccines in your office as well as other vaccinations. And then Tdap, you want to give that at the same time as your 28-week labs, which is usually either a RhoGAM, glucola. If they're Rh negative, they'll get the RhoGAM shot. But automate it so that it happens with every patient at the same time during each pregnancy. So I'm going to very quickly talk about some of the CDC internet data that came out that shows us we really need to do a better job. And these were women. It was an internet survey. They had to have had delivered a live infant by the time of the survey, and they needed to know what their vaccination status was. And so what this shows is that based on the age, and I hope you can see it, based on the age, there really was no difference between young patients and patients who are older than 35. Slightly higher vaccination rate in women that are older than 35. This shows that based on when they were, how far along they were pregnant in the survey, how many of them had received it by the third trimester, by the second trimester, and by the first trimester. And so you see most of the vaccinations having occurred by the second and the third trimester. And again, this is the flu vaccination. We'll go through Tdap here in a second. So this shows that by education level, again, we're still seeing around 30 to 40% of our patients are getting vaccinated. And I would love to stand up here and be saying, oh, we're at 75 to 80%, let's go another 20. But we're not even there yet, and we're not close to it. So this shows, and you'll see this again in the Tdap vaccination, that high school and less education level has a slightly higher rate than some college or a college degree where you start to see, and I think that might be an artifact because I would expect that the level, you might see more women in poverty who are getting their vaccinations from either a public health clinic or something like that, and that may be why you see that blip, why we have a higher rate of those who have a high school or less education getting vaccinated than women with a college education. So this shows the type of medical insurance. The bar to your left is those who have private or military have a slightly higher rate. So if you're looking at where can you grasp the low-hanging fruit, I would look at those who have any kind of public insurance. This shows, and what I like about this is that this is one of the key take-homes. If a provider, meaning a provider's office, someone in the office recommended and had the vaccine available in their office to give it to the patient, you had an over 50% or 1 in 2 women will take it. Provider says you need it, and they'll get it because you have it right there. If the provider or someone in the office just recommends that they get it, you have about a 1 in 4 chance of the woman actually getting it. And again, it has to do with the convenience. And if no one in the office recommended that they get it and you don't have it in your office, it goes down to about 6% will actually get it. So again, it's key and it's important for somebody in that provider's office to recommend that they get the vaccination, why it's important, why it's safe, why we do it when we do it, and then to actually have the vaccination there in their office. That's what's key. This shows that for women who get the vaccination, it's usually provided in a provider office, whether they're an OBGYN or a midwife or a family practice. The majority are provided in the office. Most of us don't always take the time to, go to a drugstore if it's an added inconvenience. And I can imagine if you have small kids in the car with you, you don't necessarily want to get them unstrapped out of their car seats, walk in and get it. So if you have it there easily accessible in the office, you're going to have a significantly higher uptake rate on the vaccination. This again just shows you what I was saying before was the number one reason why they received it was because they wanted to protect their infant. They had somehow gotten that message. And so if you have someone who's somewhat resistant or hesitant to get the vaccination, they're kind of a fence sitter, as I would call them, bring it up again about how that passive immunity helps their newborn. This shows that those that intended to get it, why they didn't get it was because I didn't think it was safe or effective. And so if you can eliminate those two by having that discussion in the office, you can, again, significantly increase the rate of uptake. Good God, I can hardly see that. Sorry, there's lights in my eyes. This is for those women who intended to get it and why they hadn't got it yet. Okay, I got the 30-second rule. Again, they haven't been talked to, it hasn't been recommended, and they didn't think that they necessarily needed to have it. So again, it's a recommendation. So what we know is that flu vaccination is around 1/3 of our mothers actually get vaccinated when they're pregnant. The strongest way and the best way to improve that rate is to have the provider or someone in the office recommend and then do it there in the office. And we know that 37% of those who did not have the opportunity or the time to do it did not get vaccinated. So national Tdap vaccination rate, same thing. We've seen since 2014, we've gotten our Tdap vaccination rates. The green bar has steadily increased, so we're up to about 50%. Again, if you look at age ranges, there's not a whole lot of difference. We see a little bit better rate in the middle, the 25 to 34, and that's mainly because those are having most of the babies at that point. This shows that we need to do a lot better job with our non-Hispanic, Black, And our Hispanic patients, if you're looking at Tdap coverage, again, we see this biphasic curve where high school or less are having a slightly higher vaccination rate with Tdap than some college and a college degree. Private and military does insured have a better vaccination rate than any public insurance. So this shows, again, that those women who are at or above the poverty level have a higher rate of vaccination for Tdap than those who are below the poverty level. And again, this is kind of the key takeaway slide, is if you recommend it and offer it in your office, you'll have a 70% rate of uptake. If you just recommend it but don't offer it in your office, it's about half. And then again, it's much lower if you neither recommend it or do it. I'm just going to quickly go through those. So again, our highest vaccination rate are seen if the provider recommends it, as well as having it there available in the office. You have about a 70% rate. Only 37%, or about half of those, will get it if you just recommend it. Less than 1% will receive it if you don't even mention it or recommend it in the office. So it's key. And again, the main reasons for not vaccinating would be lack of awareness, safety concerns, or lack of provider recommendations, which if you can, you would handle all those three in your office easily just by even mentioning and recommending the vaccination. So again, offer and administer the Tdap vaccination to each pregnant, assess their immunization status at every visit. And then in summary, we can and need to do a better job vaccinating our pregnant patients. That's why we're all here today, against both the influenza and pertussis. They're both safe in pregnancy, and you need to make sure your providers are strongly encourage them to get that vaccination. Inform patients about the safety of the vaccinations during pregnancy and the health benefits to the newborn, which again is a key point. Influenza needs to be given annually as an injection, and then the Tdap needs to be given with every pregnancy. And women are more likely to get it if you both recommend it and have it available in your office. And again, if you think to assess and automate the process, take it out of the physician's hands, I think you'll significantly increase your rate of vaccinations. That's all I have. Sorry. Sorry, I went over.
Does anyone have any questions for Dr. Abernathy? We have standing mics here and here. I'm kind of blinded by the light, so I don't.
Yeah, it's good, so you can't see anything. I'll be in the back if you have any questions. I went over. Sorry.
Hey, I have a quick question, sorry.
Oh, Dina.
Hi, Dr. Abernathy.
Hi, Dina.
Our health system recommends flu zone for patients up to 49 years of age, but flu block if patient has other high-risk conditions, diabetes, heart issues. Do you recommend flu block for pregnant women with those other chronic conditions?
I want to defer that to Dave.
I truthfully don't know. I work with the immunization division too. I honestly don't know about the recommendation for pregnant women, but if you want to see us at the end, we could email you once we find out the answer.
Yeah. I think one just has a little bit better coverage for those patients with chronic disease. I don't think it's going to be a significant issue with giving either one. Any other questions? All right. Sorry I went over.